All right. Good morning. Can everyone hear me okay? All right. So today's core topic is liver neoplasms and portal hypertension. It's kind of a broad topic, and I sort of, based on the core modules and stuff, I sort of try to restrict my talk so we can finish within the assigned time. Cirrhosis. So what's the pathogenesis of cirrhosis? That's important. We'll go over the causes and stuff later. So the important thing is it's caused by any sort of chronic liver injury. Could be alcohol, could be hepatitis. And the chronic liver injury results in deposition of extracellular matrix. And when you have chronic repetitive injury, you'll have excess of this extracellular matrix that will form connective tissue bridges, which links the portal and the central areas. So I want to draw a figure so you guys know. So the portal area are the ones around the periphery. If you remember from your histology, the liver lobule, the portal triad is around the periphery. You have the hepatic artery, the portal vein, and the bile ducts in the periphery, and this is your central vein. So this is the central region. So the repetitive irritation of the liver or infection of the liver causes extracellular matrix to essentially get deposited all within the entire lobule, and this is called bridging fibrosis. And then persistence of this. So there is different gradations from a histological standpoint about what bridging fibrosis is. Early bridging fibrosis is also a reversible injury, so it can be reversed, the early phase of bridging fibrosis. But if you have continuous injury and more extracellular matrix, eventually you'll develop irreversible cirrhosis. So that's the pathogenesis that SCORE wants you to know what happens. Causes we talked about. Alcohol is the most common cause here in the US, but worldwide it's hepatitis B and C. You have non-alcoholic steatohepatitis, which happens in obese patients. You can have biliary cirrhosis that can lead to cirrhosis. Autoimmune hepatitis, some metabolic diseases such as alpha-1 antitrypsin, Wilson disease, hemochromatosis. Then you have cryptogenic cause, which is, nobody knows the cause. That's cryptogenic cause of cirrhosis is one of also the more common reasons for liver transplantation. Budd-Chiari syndrome can result in cirrhosis, and finally some drug or toxin-induced injuries to the liver leading to cirrhosis. What are the complications that from cirrhosis or ramifications? You have portal hypertension, encephalopathy, renal failure, and that renal failure is more when you develop hepatorenal syndrome, malnutrition, coagulopathy, and eventually cancer, the hepatocellular carcinoma that develops from cirrhosis. So we'll focus more on portal hypertension. So what is portal hypertension? Anytime your portal pressure is greater than 5 millimeter of mercury, that qualifies as portal hypertension. However, the important thing or the distinguishing factor here is the varices of the collaterals will only develop when the portal pressures rise to about anywhere between 8 to 10 millimeters of mercury. And what's the pathogenesis? Again, not very well understood as to why portal hypertension happens. There's several different theories. Essentially, the bottom line being there is increased portal venous resistance, but this could be due to the fibrosis or the extracellular matrix that we talked about that gets deposited. That's one cause, potentially. Then another cause they've looked at is due to possibly increased hepatic vascular resistance caused by vasoconstriction from norepinephrine. And the third cause, which is the most popular theory, is hyperdynamic systemic circulation or splanchnic vasodilation due to nitrous oxide and prostacyclin that happens in cirrhotics. And it is this vasodilation which leads to hepatorenal syndrome as well. So the three possible theories as to why it happens, but the bottom line being there is portal venous resistance that is increased that leads to portal hypertension. So pathogenesis, the causes, the prehepatic cause, hepatic cause. Hepatic is further divided into pre-sinusoidal, sinusoidal, and post-sinusoidal. And then the post-hepatic cause. With regards to prehepatic, most common cause is portal vein thrombosis. This is more common in children. And when you do have portal vein thrombosis and it develops, it's not like a sudden embolus. When it develops over time, you'll actually see cavernous transformation. You'll have a lot of collaterals develop from all around the portal vein, and it's like a spider web. That's why it's called cavernous transformation of the portal vein, to allow the blood to flow through to the liver. And then another important cause of pre-hepatic, which you get tested usually on the written boards, is the isolated left-sided portal hypertension, usually caused by the pancreatic inflammation or sometimes by neoplasia. Important thing in this setting is the left gastroepiploic vein is the major collateral, and the treatment would be splenectomy. With regards to the hepatic causes now, we talked about the pre-sinusoidal. The schistosomiasis is the most common cause of pre-sinusoidal. Another important factor or important point you need to remember is the non-alcoholic cirrhosis. Any non-alcoholic causes of cirrhosis also result in portal hypertension due to their effect on pre-sinusoids, as opposed to alcoholic cirrhosis, which actually affects the sinusoids. So this is another distinguishing factor between how portal hypertension develops in alcoholic cirrhosis versus those of non-alcoholic cirrhosis. And then the post-hepatic causes, most important is the Budd-Chiari syndrome, the hepatic vein thrombosis, right heart failure, and constrictive pericarditis. So these are the most important locations where you'll develop varices. So first things first, we talked about that isolated left side portal hypertension. We talked about the left gastroepiploic vein. So if you see this comes off the superior mesenteric vein, and then it goes down, eventually drains to the splenic vein. So that's why when you do a splenectomy, that will take care of the left side portal hypertension. The most common, of course, are the gastroesophageal varices, and again, the coronary vein is the most important collateral in regards to your gastroesophageal varices, where it drains, and the short gastric. So both these combined result in your gastroesophageal varices. And sometimes I've seen it in some textbooks where they ask what's the first branch of the portal vein, and it's the coronary vein that's draining, goes up to the GE junction. Other sites are at the umbilicus, the caput medusae. Important thing is the umbilical vein drains from the left portal vein. Some of you might get asked that in your test sometimes. And then, of course, by the rectum, where the hemorrhoidal veins and the inferior mesenteric veins, anastomose. That's another important site for your portal hypertension. So the most important sequelae of your portal hypertension are the varices. 1/3 of all variceal patients will experience variceal bleeding, and each episode is associated with up to 30% mortality. An important thing to know is your risk of death is actually dependent on your underlying functional reserve. So that's important. So somebody who is a cirrhotic child C will have a higher rate of mortality compared to someone with a child A cirrhosis. Important factors in prevention in cirrhosis is you start patients with non-selective beta blocker and prophylactic endoscopic surveillance with variceal band ligation. So, and again, the indication for band ligation in setting of prophylaxis is medium to large varices. If they're small varices, then all you need to do is do this non-selective beta blocker. So Yoko, we went over this. So you have a patient who you see in clinic for, say, a hernia repair, and you get labs, and you find that patient has a low platelet count of 79. So in context of today's lecture, what are you concerned? What's your concern?
We're concerned of cirrhosis and portal hypertension.
Okay. So how would you work him up?
So you need an ultrasound or to I guess a duplex ultrasound to take a look at the velocity of the fluid going through the vessels. You could get a CT liver protocol to take a look at the liver as well. You get blood work to look at the AST, ALT levels. In the long run, you need an EGD to make sure that the patient doesn't have esophageal varices as well.
In the long run? What do you mean in the long run?
Like, not in the long run. Soon, like within.
So that's part of your workup. So when you suspect cirrhosis, you'll get an ultrasound with Doppler to evaluate for the liver size and nodularity, and to also look for varices. They look at the flows of the portal vein and stuff, and see if they're dilated and stuff. So that's the first step. And when the ultrasound is suspicious for cirrhosis, or they say that pretty clear cut, then the next step is to refer the patient to gastroenterology, or if you want to do an EGD right away. Again, to look for any varices. If somebody has cirrhosis, most likely cause they'll die early on would be the bleed from the varices. So you need to have that surveillance. And if you find medium to large varices, then you need to do band ligation, start patient with propanol. But if they're small varices, then you just need propanolol, so non-selective beta blocker. So that's important. With regards to management, we'll just go over this through see if I can find something on this score as well. We'll go over, at least go over the points first, and then we'll review that side as well. So in regards to bleed, so if somebody with varices comes in with acute bleeding, what are the important steps? You can place an NG tube. If patient is literally vomiting large amounts of blood, you may want to intubate the patient to prevent aspiration. Then first thing after that would be resuscitation. You want to give him blood products. And Schwartz, in their textbook, says the hemoglobin goal should be of 8, which is a surprise, but they say higher levels can actually result in poor outcomes. So they want a goal of hemoglobin of 8 grams per deciliter. We'll give FFP platelets as needed. Next step would be vasoactive medication, which could be octreotide or vasopressin. The idea being you want to constrict the varices, so they decrease the blood flow of the gastroesophageal varices. So octreotide is the most popular and most common drip that you would start. You could start vasopressin as well, but you'll have to start nitroglycerin with it because vasopressin will cause systemic vasoconstriction that would result in possible ischemia of your end organs. Important thing also is you need to start patients in antibiotics because anybody with variceal bleeding is prone for higher infections. Most common of these would be the spontaneous bacterial peritonitis and UTI. And so you need to start patients ceftriaxone for that. Next step would be your endoscopy. 80 to 90% of the esophageal bleeds from varices can be controlled by endoscopic measures. There are two modalities. One is sclerotherapy versus band ligation, and there have been studies that looked at the outcomes, and band ligation is really the modality of choice and not sclerotherapy in a setting of esophageal varices bleeding. If none of these work and patient continues to have bleed, next step you could do as a temporizing measure would be to place the tamponade the bleed, which could be done by Sangstick Blakemore tube or Minnesota tube. It's one or the other. So these tubes can control the bleeding in about 85% of the patients. However, these are associated with some major complications. Chief being each of these the Blakemore tube has 3 ports, while Minnesota has 4 ports. So this is your Blakemore tube. So it has 3 tubes. So one is for the esophageal balloon, one is for your gastric balloon. This is gastric, this is esophageal, and then this is your gastric port for aspiration. So, if you are not careful and there's a way of actually inserting these tubes, if you were to dilate the gastric balloon in the esophagus, that will cause esophageal rupture. So you have to be careful with this. And so the way these tubes need to be inserted is, once you insert the Blakemore tube and you feel you're in the stomach, you need to get a chest X-ray first. If you feel that you're in there, you'll see the distal end in the stomach. That's one way of confirming. But even after that, the first thing you need to blow up is your gastric balloon. And once you insert about 50 cc's of fluid, usually it's saline that you can use to inflate the balloon. After that, you'll get another chest X-ray to confirm that this indeed is in the stomach still. Once it's confirmed, then you pull back on the tube till you meet resistance, and you're probably at the G junction. That's when you would actually inflate the esophageal balloon, and that would tamponade both the gastric and the esophageal varices. So important thing is, if you're not in the correct position, if you inflate the gastric balloon in the esophagus, that can lead to esophageal rupture, so that's important. This is the Minnesota tube, and this is similar except it has 4 ports. One is for the gastric balloon, the esophageal balloon, but then there is 2 ports, one for esophageal aspiration as well as for gastric aspiration. So essentially the function is the same. As we talked about, it can lead to esophageal perforation. An important thing is, can have frequent rebleeds after balloon deflation. So not the best option, but again, you'll do it in an emergency setting where endoscopy hasn't worked and octreotide hasn't worked and stuff. And depending on what textbook you read, sometimes these will, because of the concern for necrosis of the esophagus and the stomach, some books actually recommend deflating the balloon every 4 to 6 hours to prevent necrosis. Next step, if all else has failed, would be the TIPS option. And again, you would consult IR to do that. Important thing to remember would be contraindicated in a patient who has encephalopathy, because it would worsen the encephalopathy. Finally, as a last measure, if even the TIPS fail, there are some surgical options, but again, these are associated with extremely high mortality, even up to 25%. So one option is esophageal transection. One option is the Segura procedure. It's after a Japanese surgeon, and that entails essentially doing esophagogastric devascularization. As you can see here, all the varices have been sort of ligated. You also transect the esophagus at the G junction, and then you also do a splenectomy. So that's one option. Again, has extremely high mortality. And then one last option would be you could do a shunt. And the ones that you can do in an emergency setting would be either a portocaval shunt or a distal splenorenal shunt. So in regards to the modules, we talked about the resident understand the primary management is endoscopic variceal ligation with non-selective beta blockers. So these are the 2 preventative measures that you need to take if you do see varices on EGD. Upper endoscopy is a diagnostic choice, test of choice within framework either urgent or emergent. So you need to, if somebody has diagnosis of cirrhosis, you need to evaluate for varices for these patients. Patients with variceal bleeding refractory to medical endoscopic therapy, TIPS would be the next best choice. A relative contraindication would be hepatic encephalopathy. This is important. So if the patient does have, patient came in, you got GI, they were able to scope and stop the bleeding, but if there is rebleed, then the next step is again repeat endoscopy, just like for other causes of upper GI bleed. You can always call GI again. And then the second option would be TIPS. And then surveillance is important as well. So esophageal varices, if somebody's bled and it's been controlled, you need to have surveillance endoscopies for these patients to make sure there is variceal obliteration. An appropriate level could be anywhere between 2 to 8 weeks for repeat endoscopy. So next important sequelae of your cirrhosis is hepatocellular carcinoma. It is the most common primary liver malignancy. Risk factors, cirrhosis essentially, and hepatitis B. Important thing to know is in setting of hepatitis C, you'll always have progression from hepatitis C to cirrhosis to eventually hepatocellular carcinoma. For hepatitis B, it doesn't follow the same sequence. You can have patients who may have normal liver, but if they have had long-standing hepatitis B, can actually develop hepatocellular carcinoma without any evidence of cirrhosis. So that's important to know. So the way to diagnose would be, you may want to order labs, which would be the AFP would be an important marker. Imaging would be CT and MRI. Again, the important factor to know would be that there has to be homogeneous enhancement in the arterial phase and rapid washout in early portal venous phase. So as long as the lesion meets this imaging criteria of homogeneous enhancement in arterial phase and rapid washout in portal venous phase, and you have a patient with history of cirrhosis that you know, and you have AFP that's elevated, these three criteria, as long as these are met, then patient has hepatocellular carcinoma. You don't need a biopsy to confirm that. That's important. So imaging and AFP levels will be adequate. One more thing, so if you have patient with, say, child C cirrhosis that you're following, what is the screening modality, or how do you screen these patients to detect hepatocellular carcinoma early? So your Score Portal website says it used to be previously that the criteria was getting an AFP level and AFP level and ultrasound every 6 months, which is, point that out here if I can find it. Right here. So prevention, recommended screening for hepatocellular carcinoma includes measurements of alpha-fetoprotein and liver ultrasound every 6 months. This was valid until about maybe 2 to 2.5 years ago. The current guideline, according to AASLD, which is the American Association of Studies of Liver Disease, is just getting a liver ultrasound every 6 months. So this is the current recommendation is just getting a liver ultrasound and not an AFP. So that's important to know. So that's so anybody with child B, C cirrhosis, even child A for that matter, you want to get a liver ultrasound every 6 months to make sure they don't develop a new lesion. And if they do, then you need to get that CT liver protocol and evaluate for that early enhancement on the arterial phase and rapid washout on the venous phase. So what are the treatment options for hepatocellular carcinoma? Important is the first step, or the most important one is usually transplant. You can do resection of the lesion as well. And there are other options, less optimal but still options, ablation, embolization, and chemotherapy. Transplantation, pros and cons. It certainly is the best option, has the best outcome, because not only do you treat the cancer, you also will get rid of the cirrhosis. Has the best outcomes, of course, compared to surgical resection. As I said, treats the malignancy as well as the underlying cirrhosis. The cons are, of course, you have limited organ availability. You need to be on immunosuppression for life after that. And so what's the most common malignancy associated with immunosuppression? Anyone?
Skin cancer.
Yeah. Important thing with regards to liver transplantation, hepatocellular carcinoma is the Milan criteria. You need to know that. So anyone with a single lesion that's up to 5 centimeters or less in size, or same patient can have up to 3 lesions, each one less than 3 centimeter. As long as one of these conditions are met, that patient is a suitable candidate for transplantation from a lesion standpoint. I mean, there are other things that go into transplantation, the socioeconomic factors and everything else, but from just the disease standpoint, as long as one of these criteria is met, patient is a candidate for liver transplantation. So you have a patient with cirrhosis, portal hypertension, ascites, and patient has a 7 centimeter lesion on the liver, meets criteria for your hepatocellular carcinoma from the imaging standpoint. What are your options? That's right. So chemoembolization, as I talked about, this is one option. So it's called TACE, transarterial chemoembolization. That's one option. You cannot resect this patient because patient has ascites and portal hypertension clearly past the child age stage. So you don't want to resect. Doesn't meet the Milan criteria because it's 7 centimeters. So what you want to do is chemoembolize in the hope that the embolization will shrink the size of the lesion down to hopefully less than 5 centimeters. And at that point, patient might become a candidate for liver transplantation. Resection-wise, underlying cirrhosis will determine the post-op liver failure and the recurrence. Major liver resection, if you were to undertake, as we talked about, the important thing is you can only do that for patients with child A liver cirrhosis and not B and C, because that would result potentially in liver failure and patient can die and have bad outcomes. The patient cannot have portal hypertension or ascites. Survival is about 5-year survival is anywhere between 30 to 60%, and there's a 33% recurrence rate at 5-year mark. And one last option is patient has hepatocellular carcinoma, but it's metastatic. What are your options then? Which one is that? There's one they're looking for specifically. There's only one.
Specific type of chemotherapy?
There's a name to the chemotherapy. That's right, sorafenib. That's the one that you'll get tested for it now, on it now. So sorafenib is the name of the chemotherapy that you use in setting of metastatic hepatocellular carcinoma.
Write that out on board.
Yeah. How do I do that here? I'll spell it out, I guess. It's SORAFENIB, sorafenib. And just a brief, so ablation-wise, there are 2 options. You can have microwave ablation or RFA. Both of them pretty much have similar outcomes. And both of these are adequate modalities for lesions less than 3 centimeters. So they've looked at, outcomes for ablation, and they've seen that resection or ablation for less than 3 centimeters have similar outcomes, at least in the short term, because these are relatively newer modalities. So ablation can be undertaken for lesions less than 3 centimeters. So these, just quickly go over these. Given a patient with 7 centimeter HCC in the right lobe of the liver and a non-cirrhotic ascites and variceal bleeding, chief resident can recommend the best therapy is TACE. We talked about it. 3 centimeter HCC, non-cirrhosis, multiple comorbidities. will preclude resection. In that case, you could do RFA or microwave ablation. Has good, excellent short-term results. But again, important thing is the lesion has to be 3 centimeter or less. Can't be any bigger. And then metastatic HCC to lungs. So sorafenib, as we talked about here, is what you need to know. Did you guys already do the quiz on this? Well, maybe look at, maybe do one. So you're performing a laparoscopic liver resection for an isolated 1 centimeter HCC located in segment 6. Patient 60-year-old male with childhood cirrhosis. After establishing pneumoperitoneum and dividing the triangle ligament, what's the next key step? Yeah, ultrasound. You got to do intraoperative ultrasound because you may find more lesions, and you want to make sure you get all of them. There was one on colorectal cancer, I thought I saw. So, patient 3-year status post left hemicolectomy for T3N1M0 colon cancer, and now presents with elevated CEA. CT reveals a 4 centimeter hyperdense lesion segment 5. In addition to consideration of systemic chemotherapy, which of the following should be recommended to the patient? What do you think, Lloyd? Yeah. Would you? So important thing is you don't need a biopsy, even in a setting of colon cancer. Patient has a history and now has a hyperdense lesion. You don't need a biopsy. You can just pursue surgical resection if it's something that is amenable to resection.
This would have to be implying that there's the CAT scan, say if the chest was also done. And then
Yeah, that's the assumption. Yeah.
I guess I wonder if the person is a good surgical candidate if there's 2 separate mets. Medicine.
Yeah, you could, absolutely. If there is a single lesion. Exactly. Yeah. So with a single lesion on the liver, you have a 5-year survival of about 50%. But if you have a lung and liver lesion, the 5-year survival is about 25%, but it's still recommended that you do it, that you can pursue surgical resection. Any questions? No? All right, thank you.